All right, good evening, everyone. My name is Ria Suarez with the Cancer Support Community. Welcome to today's webinar, Frankly Speaking About Cancer, Lung Cancer, Coping with Stigma, Blame, and Shame, which is hosted by the Cancer Support Community and sponsored by AstraZeneca, Bristol-Myers Squibb, Lilly Oncology, and Merck Oncology. I'd just like to go over a couple of reminders before we begin the presentation. Today's event is being recorded and will be made available on our website at cancersupportcommunity.org. If you'd like to listen to today's webinar via your telephone, you can do so by dialing in on the number that is listed on your screen. For today's webinar, our presenters will be featured first, and then we'll move into the question and answer session. If you'd like to ask a question or leave a comment, please feel free to type it into the Q&A box, which is found on the right of your screen. You can submit a question through the box at any time during today's event. At the end of the webinar, you will be redirected to the post-webinar survey. Please complete this survey as your input is of great value to us. The survey will only take a few minutes. I'd now like to just introduce the Cancer Support Community. We are an internationally, professionally led nonprofit network of cancer support worldwide. We provide social and emotional support to all people impacted by cancer, and our organization includes an international network of affiliates that offer the highest quality social and emotional support. Our mission is to ensure that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community. Listed on this slide is some of the services and programs that we offer. We have our Cancer Support Helpline, which is staffed by licensed professional counselors that are available to assist you Monday through Friday from 9 a.m. to 9 p.m. Eastern Time. We also have our Open to Options program, which is a research-proven program that can help you prepare a list of questions to share with your doctor at your appointment. And we also have listed here our Frankly Speaking About Cancer program, which is our national education series that provides information on a variety of topics that are important to people affected by cancer. I'd also like to take the opportunity to introduce our Cancer Experience Registry, which is a place where you can go to make sense of your cancer experience. You can tell your unique story, connect with others, advocate as an active member of the community, and learn from experts. If you'd like more information about the Cancer Experience Registry or would like to join, please feel free to visit the link that's listed at the bottom of this slide at www.cancerexperienceregistry.org. I'd like to also introduce our grassroots movement, which helps ensure that people touched by cancer have access to quality, comprehensive cancer care, which includes social and emotional support. Again, if you would like to learn more about our grassroots movement or would like to join, feel free to visit the Cancer Support Community website. At this time, I'd like to introduce our featured speakers, Wayne Steward and Tony Forster. Dr. Wayne Steward is an Associate Professor of Medicine at the Center for AIDS Prevention Studies at the University of California, San Francisco. His research focuses on understanding and intervening with structural and environmental barriers to HIV prevention and care. Dr. Steward is currently the Principal Investigator of the UCSF HIV/AIDS Policy Research Center, which conducts shorter and longer-term projects to address critical issues on the formulation and implementation of federal, state, and local HIV-related policies. He also leads 2 U.S.-based multi-site initiatives to improve the coordination, quality, and efficiency of HIV care in primary care settings. Internationally, Dr. Steward's research looks more specifically at the effects of stigma on engagement with HIV services. Toni Forster is happily married and surrounded by supportive family and friends. She is also a psychiatric nurse practitioner and works with patients contending with cancer and other medical conditions. Notably, she is a long-term survivor of small cell lung cancer and over time has embraced a holistic self-care practice and coaches others to do the same. Toni is currently a professor at SUNY Stony Brook and teaches soon-to-be nurses psychiatric nursing. Her goal has always been to bring to them what she has learned as a patient, practitioner, volunteer, family member, and educator. So at this time, I would like to turn the presentation over to Wayne.
Great. Thank you very much, Rhea. It looks like I have assumed control as the presenter. So, to get us started here, and I know that those of you who are listening in today, I believe your lines are muted so that you can't actually talk into the phone, but I wanted to get a sense of what you all thought stigma was. So if you have any thoughts about it, feel free to type it into the little dialog box that's in the lower right-hand corner of the screen. And I'll give you a moment to do that, and then we'll talk a little bit about how stigma is understood in the scientific literature and then its implications for lung cancer. And Rhea, I don't know if I will see everything or not.
Yep, we haven't had any submissions yet. So we can give participants a couple more minutes to submit their answers to what they think stigma is.
Don't worry, it don't have to be sophisticated or anything like that. I'm just curious what your impressions are.
We have one here. It says stigma is prejudice.
Good answer. Does anybody have anything they want to add on to that?
I think that's about it.
Okay. Well, it's a good answer. Let me make sure I can advance this slide correctly. So the way that you think about stigma, at least the way scientists think about it, is it has to do with the characteristics that I have listed up here on the slide that's currently showing. The first thing that you have to keep in mind is that stigma is a social process, and what I mean by that is it's something that happens between people. It's part of a society or culture. That's not to say that there aren't individual effects of stigma, but stigma is something that is socially shared in some way. It's not something that solely rests within one single person, but it's part and parcel of, it's actually part and parcel of the way that societies regulate behavior. Right, and the kind of more formal definition of what specifically stigma is this idea that it results in some sort of discrediting or devaluation of either a person or a group. So it's the idea that a particular individual or set of individuals end up having some sort of lesser social status in response to some characteristic that they have. And the important thing here is that the stigmatizing behavior can either result from real or anticipated experiences, and that becomes important in understanding what its effects can be. So sometimes there's there's actually something that happens in the world and people respond to it in a stigmatizing way, and other times there's situations in which someone expects there to be stigma and then they take action in order to avoid it. So in terms of understanding a little bit about what tends to get stigmatized, when you look across various conditions and you study stigma broadly speaking, there are certain patterns in terms of what kinds of things end up being stigmatized. And these include the conditions that I have listed up here. That is that a person can be seen as being responsible for the condition in some way. Another characteristic is that a condition is seen as contagious. Another would be that the condition is seen as degenerative, yet another as unalterable, and another as readily apparent to others. And if you think about the kinds of things, not just limiting ourselves to lung cancer for a moment, but just thinking broadly about the kinds of things that we know of that get stigmatized, you'll see that a lot of these things should resonate. So if you think, for example, about something like, for example, take something like the Ebola outbreaks that occurred within I guess it was about a year ago at this point, or a little bit less, right? Ebola is a very deadly disease. Once you have it, it's difficult to fight it, and it runs a high risk of death. And what you saw as Ebola was happening, including some of the cases that you saw here, you saw some very pronounced efforts to deal with it, some of which were arguably considered to be stigmatizing. In fact, there was the case of the nurse who came back from, I believe she was a nurse, who came back from treating Ebola patients overseas and was detained at one of the New York airports, and she made a pretty strong case about her civil liberties being denied because of the presumption that she might have Ebola. And so it's just an example of the kinds of things where you tend to see stigma pop up for one reason or another. When we're talking about lung cancer stigma, and also when we're talking about HIV stigma, which as Ria, when she introduced me, you could hear, right? And most of my own research is in the field of HIV, which is, of course, a disease for which stigma has had a very large impact over the history of the epidemic. But for both HIV stigma and for lung cancer stigma, really there's two of these that are important for us to talk about. One is this sense of responsibility, and the other is this sense of the disease being degenerative. In the case of HIV, of course, there's also the issue of contagion comes into the picture, which is not the case with lung cancer stigma. So let's talk for a moment about this idea of responsibility. I'm going to move back and forth here a little bit between HIV stigma and lung cancer stigma, partially because HIV is my area of expertise, and I study a lot about that, and then I can show you how the similar kinds of lessons get applied with lung cancer stigma. So with HIV stigma, one of the major reasons why the disease was stigmatized from its very earliest days had to do with how it was contracted and who had the disease. And the fact that HIV disproportionately occurs in communities or individuals that would be stigmatized for other reasons. And so that stigma played part of the reason that HIV stigma sort of took in such a strong form was the fact that people held some of those groups responsible. So this would include gay men, injection drug users. Early in the epidemic, interestingly enough, you had things like hemophiliacs, and Haitians was one of the famous ones very early in the epidemic. But gay men and injection drug users were held as being particularly responsible for having acquired HIV and were particularly stigmatized because of it. By contrast, individuals who picked up HIV through, say, the blood supply as part of a blood transfusion, or were hemophiliac and thus getting regular transfusions in order to have platelets, as well as, of course, individuals who were, say, infected, what they would call perinatally, meaning you were infected at birth, those individuals were seen as being much less responsible and received much less blame, consistent with this idea that those who you stigmatize are those who you accord responsibility to for having their disease status. Now, if we look for a moment, if we now turn our attention over to lung cancer and we talk for a little bit about what happens with lung cancer, the research has shown that this exact same effect does exist for lung cancer patients. And I'm going to note, I have a number of studies I'm going to talk a little bit about during the course of this conversation. And one of the things I just want to highlight before we get into them is you're going to notice that a lot of them were conducted elsewhere, not in the United States. And I actually don't know where all of you are from, but if you're from the U.S., you will notice that not all of them are conducted in the U.S. In fact, almost none of them are. And when you look across the lung cancer stigma literature, this is actually something you see quite readily, and it contrasts very heavily with what you would see if you were looking at the literature for, say, HIV stigma or stigma against some other kinds of diseases, and itself is probably indicative of how lung cancer stigma gets stigmatized within the research literature and by individuals who are working in theory to respond to lung cancer stigma. But as we talk here about lung cancer specifically, I want to just tell you for a moment about this study that Marlowe and colleagues conducted, in which what they did was that this was a study that was done in the United Kingdom, and they asked 1,200 individuals. These were not individuals who necessarily had cancer. It was a random sample of people, but representative of the population of the UK. They called up people, or actually they did it online. They contacted people and got them to respond online. And each person was asked about one type of cancer, but they varied what the type of cancer was, so that a person could be asked about either lung cancer, bowel cancer, skin cancer, cervical cancer, or breast cancer. Each person only was asked about one of those, but all 5 of them, across the 1,200 people, all 5 of those ended up being assessed. And as part of the assessment, what they were asking people to do was to talk about their response to the particular kind of cancer. And they measured this on 5 different kinds of ways that you could respond, all of which would relate in some form or fashion to stigma. One would be awkwardness, that you would experience, you would feel uncomfortable, feel awkward having to talk to someone who had the particular kind of cancer. Another would be that you would assume that getting that particular kind of cancer was essentially a death sentence, that it was highly likely it was going to lead to severe disease and death. The third was that you would try to avoid people who had this particular kind of cancer. The fourth area asked people about their support or opposition for particular kinds of policies, and basically wanting to know whether or not people thought that you should prioritize treating this cancer, and if you didn't want to prioritize, if you were opposed to that, it's a sign of stigma. And then the fifth and final area, which is the one relevant to what I'm talking about here, is personal responsibility, the assumption that an individual who has this kind of cancer is somehow at fault for it. And what they found when they looked at these 5 kinds of cancers was that lung cancer elicited more stigmatizing responses in all 5 of these areas when it was compared against cervical cancer or breast cancer. So basically, people with lung cancer were more likely to elicit awkwardness, a sense that the disease was severe, wanting to avoid the person, opposition to prioritizing money for this cancer, and a sense that people were personally responsible for the cancer. Similarly, when compared against colorectal cancer, lung cancer was also rated as more stigmatizing in all of those areas, except for one that I have somehow written down here, except for awkwardness, buried in my notes here. So that what you end up seeing here of importance is that people were considered to be more at fault, consistent with the literature, when they had lung cancer than when they had any of these other kinds of cancers that were being assessed. There's also, kind of related to this, there was another study that was done by McKinsey and colleagues, and this was one that was done, this was done in Sydney, and they actually, for a period of about 5 years, they managed to track all of the news reports that appeared on the free TV stations in the Sydney area and logged all of the times that those particular cases talked about specifically lung cancer and even more specifically, times where somehow they managed to make mention of the fact that the person or the set of people being featured in the story, they made certain to mention that they were individuals with lung cancer who had been non-smokers. And what they found when they reviewed all of these different media reports was that when the news media was reporting on non-smokers, it was repeatedly presented as the non-smokers being victims who had sort of surprisingly come down with lung cancer, with the implication being that smokers were more responsible for their condition, less surprising, and generally less sympathetic. Again, consistent with the idea that those who were perceived as responsible for their conditions were the ones eliciting stigma. And I did find this little graphic that's at the bottom of the slide, in which, as you can see, they basically use cigarettes as they try to link cigarette smoking with lung cancer and the serious consequences that come from having smoked. And we will come back to some of these media images and kind of how one counteracts them. The next area I just want to talk about that was another area that relates to what gets stigmatized is this belief about severity. And of course, with HIV, one of the other major reasons why HIV was so heavily stigmatized early in the disease was that it couldn't be treated, and it didn't just lead to death, but it made for a very kind of gruesome and visual death that appeared on the news media quite frequently. That has changed over time as treatments have become available, but it certainly was true in the early years of the epidemic. The same is actually true of lung cancer. I mentioned a moment ago, 2 slides ago, when I was talking about the Marlowe study, that one of the areas of stigma that they assessed, or one of the reactions that they assessed, was people's belief that a particular kind of cancer would automatically lead to death, which is, of course, a way of asking about its perceived severity. And lung cancer was, of course, perceived as being more severe than breast cancer, cervical cancer, colorectal cancer, and skin cancers. But it's worth noting that you don't actually even have to go to the literature to see examples of this. The graphic that you see at the bottom of this slide is actually one that I pulled from a document that the American Cancer Society has made. And, you know, the American Cancer Society is obviously not out there to try and promote stigma against lung cancer. And the graphic that you see here can be used to make a number of points. Right? I mean, what it shows is that your deaths from cancer, from lung cancer basically, are higher than when you combine the deaths from colorectal, breast cancer, and prostate cancer. And, you know, there's reasons why you might make this argument. One of them, for example, being if you're arguing to allocate funding towards something. You might also make this kind of argument when you're trying to put out a message about preventive stuff, like don't do this behavior, don't do that, to try and reduce your risk of something. The problem with this kind of graphic and this kind of message is that once a person is diagnosed with lung cancer, this is a very deflating kind of message. It sets the tone that lung cancer is difficult to treat and that it's kind of got a doomsday situation to it, or a scenario to it, and that reinforces the stigmatizing beliefs that lung cancer patients then have to deal with. So let's talk here. So having just now talked about the fact that lung cancer is tends to be stigmatized because people are seen as responsible for it and because it tends to be seen as being severe. Let's talk a little bit about what the implications of that would be before we get to how you'd counteract it. So stigma can do a couple of different things. One of those, of course, is it can lead to certain kinds of behaviors between people, namely blame and discrimination. And there have been studies that looked at this. There's this one study that was done by Wassenaar and colleagues, in which this was the kind of study where they sent the particular instrument that they sent off and the particular participants they recruited were all providers. They were physicians. And they gave them scenarios and asked them how they would, scenarios of patients that are coming to present with a particular cancer diagnosis and what the provider would recommend and how the provider would respond. And they varied whether or not the individual was described as having breast cancer or lung cancer, and then they also varied whether or not the person was described as being a smoker or a non-smoker. And what they found was that physicians were less likely to refer patients who they, or at least in the scenarios, they were less likely to recommend a referral when the patient in the scenario was described as having advanced lung cancer than when they were described as having advanced breast cancer. The physicians also knew, they were more likely to know that the chemotherapies could improve survival in advanced breast cancer, then they knew that that chemotherapy could do the same thing for advanced lung cancer. So they were less likely to make a referral, and they were less likely to know that there was an effective treatment option for people with advanced lung cancer. And when they did refer lung cancer patients, or they recommended referral in this scenario, they often did so because they were trying to control symptoms rather than necessarily treating the disease, which goes hand in hand with not understanding that chemotherapy could actually effectively treat advanced lung cancer. And so, interestingly, there's a couple of interesting things that go along with this. One, smoking status in this particular case actually did not end up differing in terms of what the physicians did. It was the fact that patients had lung cancer that seemed to be particularly problematic in terms of what the physicians actually did to respond to it. The second thing, and this is important, is the physicians didn't actually think that type of cancer was in any way shaping their behavior and what they thought they should do with the cases. They thought they were just applying good clinical knowledge. They didn't recognize the sort of belief structures out there in the world, some of which are stigmatizing, might be influencing how they would be responding to patients. So that's a kind of example of what can happen between individuals. And obviously, stigma between individuals is not limited to a doctor-patient relationship. There can certainly be discrimination within families or between friends and just out there in the kind of general, like when you're out and about on the street, particularly if someone is perceived as having, is known to or perceived as having lung cancer stigma. There's also the effects that stigma can have within yourself, and that's, those really take the form of shame or anticipating that you're going to encounter prejudice and then seeking to avoid it. And so an example study from the lung cancer literature that reflects on this is this one that was done by Chambers and colleagues, in which here again it was conducted in Australia, in Queensland and New South Wales, and it was a survey that was given to about 150 people who had been diagnosed with cancer. And as part of the survey, they had a measure of stigma, and it captured the degree to which people were experiencing shame, social isolation, discrimination, and elevated and basically stigma tied to smoking. So you have shame, social isolation, and discrimination that would be basically broadly applied to people who were experiencing that because they had lung cancer, and then to what degree people were experiencing stigma because they were perceived to or had smoked. And what they found was that those who reported more shame and discrimination also reported higher anxiety. Those who reported more shame also reported experiencing more depression. And then shame was also associated with reduced quality of life, which was a measure that looked at your sort of overall well-being, both your physical well-being, your emotional well-being, and then even your social well-being, the degree to which you had an active social life and friends and things like that. So what you see is this kind of shame, this sense of shame that's happening within people. So another study that was done was one that actually looked at the fact that lung cancer stigma can lead to delays in seeking medical help. And this is actually a very important thing to understand. And this study isn't the only one that has looked at this. And this is actually a finding that comes up and pops up across the literature when you're talking about stigma against diseases, and that is that when somebody has a stigmatized disease like lung cancer, not only is it the case that a physician or a provider may respond to you in a less friendly way, or as that study I was just talking about a moment ago could happen, respond to you in a way that reflects less knowledge of what can be done and a belief that there's less that can be done for you. But there's also the effect that patients won't go to the doctor, that they delay care, usually to a point that the disease is much worse before they will actually seek treatment and help from a provider. And this, of course, is obviously counterproductive. It does not, with a disease like cancer, it does not help to delay getting the care that you need because it allows the cancer to grow unchecked. But that's exactly what does happen in lung cancer and what happened in this study with patients who had been diagnosed with it and who perceived there to be stigma. They were less likely to seek care as quickly as possible after the diagnosis. So that takes us now to this question of what we can do. I've sort of talked about, why lung cancer gets stigmatized, the impact of it, and then what can be done to actually try to counteract it. And as a reminder, of course, lung cancer is perceived to be severe and untreatable, and it's perceived as being something that people may have some responsibility for having acquired. And that becomes important in thinking about what would you do to try to counteract it. So there's a number of different things that become important. And I talked a little bit here about the kind of messaging that one can do. And it's important to remember that messaging can be done at a couple of different levels. There's kind of the messaging, by messaging I mean what you would tell people. And this could be something as simple as when talking to somebody else that's your friend or a family member, or we could be talking about messaging in a kind of bigger picture sense, like you're trying to run a campaign to counteract stigma or something like that. Right? But one of the first and obviously very important messages is that people can and do survive lung cancer, right? There's the belief that I talked about a little while ago that lung cancer is severe in this sense that there's not much that can be done. And while it is the case that there are relatively high numbers of people who end up having death from lung cancer, it is by no means the case that having a lung cancer diagnosis is an automatic death sentence, and it is by no means the case that there's nothing that can be done to try and reduce the likelihood of that. It is extremely important for someone to get medication, get treatment, get chemotherapies, right, and to deal with the cancer. And so one of the most important things for people to understand is that if you get it, there are treatments and that you can survive it. Referencing back to the HIV literature for a moment, it's worth just noting that you don't even have to have the message be focused on stigma. Once effective HIV treatments became available and the pharmaceutical industry in the United States had a profit margin or a profit oriented reason for wanting people to take those drugs. The pharmaceutical industry has done its own to try and counteract the stigma against HIV, and it did so by advertising. They would put out all of these ads of people like climbing mountains and living this kind of healthy lifestyle. It would never say HIV shouldn't be stigmatized. It would just simply say you can be healthy and well and happy and everything going well when you have HIV by taking our drug. And, you know, it's obviously the reason for it there had to do with the wanting to sell the drug, but it shows you that you can actually work to counteract the kind of prevailing beliefs around stigma by simply focusing on the fact that good treatments do exist. Another kind of message that is useful in trying to counteract the effects of stigma is going to be changing people's associations or changing people's assumptions about smoking, right? Lung cancer ends up being stigmatized because people are seen as responsible for it. And they're seen as responsible for it because there's a set of beliefs around why it is that people smoked, and to put it crudely, the assumption that people weren't being responsible and they smoked and they brought it on themselves. So if you want to challenge that belief, it's useful to challenge the beliefs around smoking. And, you know, there's a number of things it's worth remembering here. One is that, of course, smoking usually starts in response to some sort of social or institutional pressure, and it often happens at an age where we hold people less responsible. They're young when a lot of people start smoking for the first time. Another one is that, you know, once you start smoking, you often continue smoking because it's an addiction. It's not just about whether you want to quit or not. It's a physical reaction in your body that keeps you smoking. A third, very important one, is the fact that historically there was a lot of misinformation put out there by the tobacco industry in order to try and cover up the fact that research was showing that smoking was bad for your health. And that the tobacco industry tried to cover this information up while at the same time advertising smoking, and that people who in many cases took up smoking did so based on false information. And then, of course, there's also the fact, and this will relate to something else I'm about to say in a moment, right? We all know somebody who smokes, right? And we would want them to be treated well, too, if they ended up having lung cancer. There's also, of course, another message around supporting one another and knowing your allies. And this is important not only for counteracting the effects of stigma, but also for coping with it. You know, there's a certain amount we can do to try to stop stigma, and then there's a certain amount of knowing that it's going to be out there and in the environment and how we deal with it. And having a good support structure around you is important for that. So knowing your allies is important because having those allies and having those friends helps with living with stigma on a day-to-day basis. But it's also a message that it can be useful for resonate, like to help counteract stigma and help people to resonate with the experience of someone who is living with lung cancer stigma. And that is that we've all had friends and family who've had cancer. It may be lung cancer, it may be another kind of cancer, and how do you want that person to be treated? And would you want them to experience stigma? And I mean, I had a very close family member who had breast cancer, which does not necessarily have the same set of beliefs about responsibility, but I do know that, you know, breast cancer patients also end up being stigmatized. And, you know, as a person who lived with somebody who had breast cancer, I didn't want that person to be stigmatized. I wouldn't want a person who has lung cancer to be stigmatized. This kind of messaging is also helpful. And there's also a kind of final thing that's important to think about in terms of what you can do to counteract the beliefs of stigma, and that is disclosure itself. In the world of HIV, the advocacy group ACT UP took the slogan "Silence equals death." You may have seen it on, used to have it on stickers and all things like that, and whenever an HIV rally would happen in a city, you'd see the stickers all over the place. But that message of silence equals death emanated from the idea that if people with HIV kind of lived with it quietly, shamefully, and didn't speak about it, you couldn't expect there to be a change, both in kind of the day-to-day, how people reacted to individuals with HIV, but also in terms of the amount of money that went for things like HIV research. And so a major emphasis in the HIV field was put on the importance of saying that you have HIV so that people would realize they knew somebody with HIV. And the same is going to be true with lung cancer. If a person doesn't tell people that they have cancer, or if they misrepresent the cancer as being something else, then you're not doing anything to kind of challenge the belief structures, the stigmatizing belief structures around lung cancer. And a big part of it is being able to say, I have lung cancer, and to show people that you're living with it, that you're fighting it, that that you deserve it. They know you. They would want you to be treated with respect. And then that helps them to think about how they would want other lung cancer patients to be treated as well. So those would be the four that I would say, based on the literature, are the kinds of messaging and the way to think about how you counteract stigma on a day-to-day basis. And with that, we're going to turn it back over to Tony, who's going to talk a little bit about her experience. And when we come towards the end of the session, we'll come back to talk a little bit, very briefly, about how Tony's experience relates to some of these things that I've just been talking about here.
Thank you, Wayne. Thank you for inviting me to this webinar. I'm very excited to be here and to share my story and participate in this fantastic discussion. I was diagnosed with small cell lung cancer at 38 years of age. By the way, my name is Antoinette Forster. And having been a nurse for many, many years, I always knew the risk factors related to lung cancer, obviously. And despite that, I moved along smoking, and happily smoking, as a matter of fact. And when I was diagnosed, this truly was my worst nightmare happening. After the diagnosis, Wayne beautifully described very much the overwhelming and unbelievable experiences that evolved from having self-blame and stigma associated with the fact that I caused my disease because I smoked. And the emotions were very, very complicated. I had a lot of anger. I had a lot of sadness. I had a lot of shame and guilt. I always felt terrible looking at my husband's face and my family's faces because they had begged me for years to quit smoking, but I continued. So that piece was probably the worst part of the diagnosis, is facing my own shame and then facing the shame that I felt people felt towards me. So it was a very tough struggle and a tough period of time dealing with it. I found that many people became very anxious and insensitive to my dilemma. It ran the continuum. Because I was a healthcare worker, it either went from people just, pretty much offering me so much, material around lung cancer. And of course, early on, this is a long time ago, there were very few really curable treatments available. So they were giving me basically a death sentence. So finally, I just became very overwhelmed with the volume of paper that people were offering me in their goodness. And I just had to stop that because it was just burying me in the experience. I also had actually family members tell me that I really should have known better, that I really should have known that this smoking was going to make me sick. what made me sick was the family member telling me that it was going to make me sick. And reminders of that, frankly, didn't help my healing at all. It really enhanced my self-blame. And it created a level of depression pretty much for a while, probably 3 to 6 months, where I really couldn't function. I couldn't look at myself in the mirror. I didn't recognize who I was when I dealt with the chemotherapy and all of the after effects of chemotherapy. So that compounded my self-punishment, frankly. Boy, I sure deserve this. So that became very, very much a suffering component. And I want to reflect for a second on Wayne's discussion on Marlowe's literature earlier on. I remember part of my anger was directed at the lack of research around lung cancer specifically. I felt, gee whiz, I would have been better off getting breast cancer or colorectal cancer because there's a ton of research going on. And 23 years ago, there was very, very, very little research being done on lung cancer, and very little hopeful outcomes that were discussed by physicians and otherwise. And I was mad about that. I was mad that why isn't something happening with this, since lung cancer, has the highest rate of deaths from cancers overall, although much, much better these days. Many, many people are surviving this. However, from that moment on, once I was able to get out of the bed and move forward and talk about how there are many people in my life, and I'm sure yours, that have made the right decisions or the wrong decisions, or there were things that they did do or didn't do that may have created a situation affecting their health. So I got to the understanding that all of us kind of sit on something, and there are all of us that have not done things that we should have done, or did things that were inappropriate or unhealthy. So I started the forgiveness process, and many of the people that I least expected, virtual strangers in many ways, really came forward and offered me ways to heal. And really injected a lot of hope in my ability to survive, which I didn't feel throughout the beginning of the diagnosis. Eventually, I was really able to let go of my guilt, and I was really able to let go of the self-blame, and I was able to move forward. I actually, over time, I returned to my original professional passion. During the time of diagnosis, I was an administrator, a really hateful job. I was in middle management and always not good. But I returned to my original professional passion, which is psychiatric nursing, which I still do today. And I was able to complete a master's degree and then a doctorate in nursing. In the beginning, it was doing the master's was kind of a distracting feature, that I didn't have to be ruminating about the cancer diagnosis constantly. So, interestingly enough, it just started as a distractor, like playing Scrabble. Instead, I chose to go into a master's program. But it worked very well for me through those early years of survival. And I'm pleased to have had that option to do that. I also embraced a more holistic view of how my own healing should look like. When you talk to physicians, and as a matter of fact, I had a fantastic oncologist who I still see to this day and is just a wonderful human being. But they really did, at the time, they really didn't have much to offer outside of the box of chemotherapy and radiation therapy and such. So I had to begin to look outside of that and grab a hold of things that were not only being offered to me, but things that interested me. So I learned how to play Mahjong. I became a Reiki master. I was always fascinated by energy work. I joined a book club, loved reading, and I actually started a meditation practice that I do today and teach to others. All of these pieces really, really got me on the track of healing and less illness-focused and more back to who I am and who I always was, which was a healthy person with a healthy soul and wanting to move along. I struggled often with this issue of stigma in relation to if I had friends. I remember distinct experience of a very good friend of mine whose intent was good, let her kids know that I was diagnosed with lung cancer, and I guess painted a very bad picture that I was going to die. And I remember these children riding their bikes, passing me by on the sidewalk and just looking at me, terrified, that I was going to die right in front of them right that minute. And I was upset about that. And she herself had this image, the mother, my friend, that I was going to die. And so those kinds of people in my life at that time were toxic. So I had to sort of reduce my exposure to them because it was not a good thing. And I, in my work as a volunteer and working with cancer patients, I often talk about that, that what's toxic for us in our healing is not good, and we have to reduce our exposure to that. So I was able to do that. Never much of an assertive person, but that sure got me to be very assertive. I found that people are very curious when a lung cancer diagnosis is rendered. Almost the first question, if not the second question, is, were you a smoker? And in the beginning, I used to get really, really irritated about that. I could think of 1,000. I'm a New Yorker, so I could think of 1,000 comebacks, very quickly that I wanted to inject. But I had to kind of struggle with it internally and move through that. Decades later, people will still, if they hear about my history, which I really don't volunteer unless, I don't know, if it comes up in some kind of way. But if I am asked if I smoked, it's still a troubling question because I think it's still related to, that I was this stupid idiot that smoked, and, well, that's what you get kind of thing. And so I still struggle with it, but I'm able to sanely answer it without getting too upset. So what I'd like to offer listeners today and viewers of the webinar is a meditation exercise, which is very nice and very relaxing and easy to remember, and it is included on your slides as a reference that you can use over time. So if you'd like, we can begin now. And if you can, I'd like you to get comfortable wherever you are, in your chair, on the couch, and I'd like you to really be conscious of dropping your shoulders. I find that more often than not, we walk around all day very unconsciously with our shoulders hunched up, and we don't even know it. So if you can for a second, just render your attention to your shoulders and gently drop them. And if you will allow yourself to close your eyes, that would be great. And when that has happened for you, begin to take some nice, gentle breathing. Breath in through the nose and out through the mouth. And in through the nose and out through the mouth. And if you can, I'd like you to use your imagination to think about this beautiful heart in your chest beating lovingly and steadily, sending its healing warmth and energy to every single cell in your body. So focus on that if you can for a few seconds, breathing gently into it and watching your heart beating this beautiful energy into every single cell in your body. And then I'd like you to listen to these wishes that I have for you in this meditation. And these are your own wishes for yourselves in your healing. And they are, may I be safe, may I be healthy, may I be happy, may I live with ease. May I be safe. May I be healthy. May I be happy. May I live with ease. Breathe gently in and out. And breath in and out. And if you can, once again, simply shift your focus on your heart and its healing, loving energy. And just for a few seconds, I'd like you to imagine the faces of those whom you love and those who love you. Embrace them into your heart's energy. Breathe into that gently. And impart these very same wishes for them. And they are, may you all be safe. May you all be healthy. May you all be happy. May you all live with ease. May you all be safe. May you all be healthy. May you all be happy. May you all live with ease. And now, as you prepare to come out of this meditation, take 3 cleansing breaths in through the mouth and out through the nose. And in through the mouth and out through the nose. And in through the mouth and out through the nose. And whenever you're ready, open your eyes and enjoy this loving, healing energy throughout this evening. Thank you.
Thank you, Toni.
You're welcome.
At this time, I would like to open up the presentation to the audience. And again, thank you for those of you who have submitted some questions. But if you would like to submit a question, again, you can do so by typing it into the Q&A box or the chat function that is found on the right of your screen. Wayne, did you want to go through this slide first, and then
as you're thinking about your questions, I did just want to highlight that some of the tie-ins, and Toni noted these as she was talking through her story, in some of the ways that they tie to the kinds of stuff that I was talking about earlier. She talked about experiencing blame, shame, and depression. She talked very eloquently about how she felt, about the sense of failure that she had, and the sort of shame that came from knowing that she had smoked and feeling like she'd let people down. And then she talked a lot about the path to healing and self-acceptance and how it was important to find those who could support her. And they weren't necessarily people who were in her social environment at the point that she was diagnosed. They were new individuals that she found. And, you know, she's able to speak about her experience now, and to recognize that others, when they ask questions like about whether or not she smoked, and ask questions about her lung cancer, that they're really reflections of their own anxieties, not particular judgments of her. And so the tie-ins, I mean, her story nicely, it provides a kind of vivid anecdotal personal experience that matches all of those different kinds of things that I was talking about earlier, those larger points that were being raised at the beginning of the presentation.
Okay, great. So we do have a question here, and Wayne, if you want to provide some insight on this, but it says, heart disease that is directly linked to smoking doesn't have the same stigma as you see with lung cancer. And do you have any insight on why you think that is? It's a good question, actually. It's a very good question. And I'm not going to be able, off the top of my head, to point you towards research on it. But if I had to speculate on it based on my own knowledge of this, my guess would be that it's partially has to do with the fact that lung cancer is very uniquely associated in people's minds with smoking. And smoking itself is very much vilified. I think it's probably fair to use that word, vilified, in terms of the way that messaging around it has moved over the past few decades. Right? I mean, smoking itself, of course, has this really strong negative connotation, and then the kind of problems that come from your lungs as a result of it are very much seared in people's minds. I think that the public at large is less aware of the kind of damage that smoking can do to the heart, less aware of the fact that it's a major contributor. And I think when you hear, when people talk about heart disease, I think the kind of thing that people think of, if they're going to think of anything sort of like personal, in the personal responsibility realm, I think they think of things like eating fatty foods and not exercising. And they fail to keep in mind that smoking is actually part of it. And so, and I think, I mean, just to be blunt about it, I think there's just a lot more Americans who have challenges with things like being a little bit overweight. And so it's harder for people to, I don't want to say that there's not stigma against people who are obese, because there's actually very strong stigma. But I think the stigma, I think it's more complicating for people to make really strong blame attributions based on not eating well and not exercising every day, because I think a lot more people do that. And I think when it comes to lung cancer, people are only thinking about smoking. And I think when first of all, there's just fewer people who smoke. And then secondly, you look at the kind of language around smoking and the way people talk about it, there's just really harsh belief structures. And that I think that's the reason that you end up seeing so much more stigma against lung cancer than you do against heart disease. Great, thank you. Wayne, you talked earlier about the different types of stigma that lung cancer, or people diagnosed with lung cancer, can experience just from an individual standing point or socially. And you had also talked about stigma experienced from the healthcare team. And we had a specific question here that asks, were these family medicine physicians? Do you have any insight into that?
You know, it's a good question. I would have to go back to that specific article to look at what what kind of providers they were exactly. My sense is they were primary care providers, but I don't have the article in front of me right at the moment. But knowing something about the United Kingdom's healthcare system, which there's less emphasis on specialists there, my guess is that that's probably the case, because a family medicine physician or some sort of primary care physician would be the kind of individual who would be responsible for referring someone on for more specialized care.
Okay, great. So again, I'll give just a couple more seconds for those of you who would like to submit some questions before we end today's event. I'll wait a couple more seconds for you to type that in. We have a question here for Tony. It says, Tony, if you would like to share, how many years cancer-free are you?
I am 23 years cancer-free.
Yep. Well, congratulations.
Thank you.
And the person that asked that question says congratulations.
Oh, thank you.
Okay, great. So at this time, we do not have any additional questions. I would like to point you to some resources, though, that we do have here. So if you'd like to learn more about lung cancer, have some additional questions, please feel free to visit any one of the resources that are listed on this page. Wayne had also provided some of the lung cancer stigma studies. If you're interested, please feel free to check any one of these out as well. And then lastly, on this slide, this was the guided imagery exercise that Tony had walked us through. I will make these slides available to all those who registered, so please be on the lookout for an email. Once this webinar is recorded and posted, I'll send out an email which will include the complete slide deck with all of these notes. So thank you to all of our attendees for your questions and your enthusiasm throughout today's presentation. We would like to thank our wonderful speakers who did a wonderful job today, Wayne and Tony. Thank you for contributing your time and sharing this important information with us.
You're welcome.
CSC would also like, thank you. CSC would also like to thank our webinar partners, Free to Breathe and Lung Cancer Alliance, as well as our program supporters, AstraZeneca, Bristol-Myers Squibb, Lilly Oncology, and Merck Oncology. You will now be redirected to our post-webinar survey. We appreciate any feedback that you may have. I hope you all have a great night.
Thank you, Rhea.
Thank you. Thank you, Rhea.
Thank you.
Thanks for the guidance.
Thanks, everyone.
Bye-bye.
Bye now.